Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to our other Skin Chat. Tonight, we're going to talk about psoriasis and skin barrier dysfunction, the role of gentle cleansers and moisturizers in treating psoriasis. As speakers, we have Dr. Leon Kursic, who's president of the International Dermatology Education Foundation, clinical professor of dermatology, Icahn School of Medicine at Mount Sinai, Indiana University Medical Center in Indianapolis, Indiana, and medical director of physician skincare, derm research, and skin sciences. We also have Dr. Charles Lin, who is chief medical director, the Linde Institute for Dermatology and Linde Derm Research, associate professor, University of Toronto Department of Medicine, and investigator of poverty medical research. And Dr. Lin is located in Markham, Ontario. We also would like to thank our sponsors, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. If you could fill it in for us and send it back, we truly appreciate it. Within 1 to 2 days of the webinar, a certificate of attendance and the recording of the webinar will be sent to you. Again, if you have any questions for our faculty, just use the question chat pane on the right-hand side of your screen, and I wrote a little note there so you could see where you needed to type in your question. So without further ado, I will pass the floor virtually to Dr. Lin.
Thank you very much, Roxanne, and welcome everybody to Skin Chat. Tonight we're going to talk about psoriasis and the skin barrier dysfunction, the role of gentle cleansers and moisturizers in treating psoriasis. So we're going to have an initial polling question here. This is just to start the evening and see where everybody's at. So prior to coming to this webinar, did you feel that psoriasis is a skin barrier defect disease in any way? You can answer yes, no, and maybe some people are considers, and maybe you're going to answer maybe. So everybody can vote, and we'll go on. Ashley, will you start the poll? Okay, so in fact, a lot of people go, yeah, it is a skin barrier defect. And I think that's Dr. Kursic and I are going to show you that it is. And there's still some fence sitters, and so some people are going to have to hopefully learn a little bit tonight. But I think tonight it's very interesting. I think this is a new concept because really until recently, we really didn't think of this as being a skin barrier defect. This was something that we knew certainly about acne. We knew about rosacea. There was a skin barrier defect, and I think these the sort of parallels are similar. We knew that atopic dermatitis certainly had a skin barrier defect, and I think at the present time when you're counseling your patients with acne, rosacea, atopic dermatitis, you always say, listen, you have to use this cleanser, you should put this moisturizer on, etc. However, I really was never taught, and I don't think we still teach this to any of our residents, that it's also important in psoriasis to consider this barrier and fix it, and hopefully you get better compliance and our treatments work better. So tonight, these are the objectives, understand and better understand the unique aspects of psoriasis and the skin barrier, discuss the nuances in the treatment of psoriasis and the skin barrier, and again, the role of moisturizers and cleansers in treating psoriasis. And so there was an interested group of key opinion leaders that got together. And we thought, let's look at the evidence surrounding this. And Dr. Kursic, myself, were part of this panel, but certainly also Dr. Alexis was, Linda Steingold. We all sat around and did a literature review and looked at it. And this was a poster at the Fall Clinical in September of last year. And we basically, out of this, we reviewed the literature and then basically said, While dermatologists may begin to consider the role of skincare and barrier restoration in treating psoriasis, there's actually a relatively new concept. And unlike the concept around atopic dermatitis, acne, and rosacea. And again, there's a need to develop more robust body of evidence in skincare to influence clinical practice in a meaningful way. And this was the poster. Similarly, we turned this into a manuscript, and it has been submitted to JDD in December, and hopefully will be published and accepted soon. And this is some of the things that, in terms of the introduction for this manuscript, we recognize that it is a chronic immune-mediated dermatologic disorder. We recognize that lesional skin has a lot of inflammation there that's going on, but there's still a lot of insufficient evidence about the skin barrier function in psoriasis. And in the review, we discussed the potential role that gentle cleansers and moisturizers may help with this barrier. Just a few things about psoriasis. We recognize that it's more frequent in adults. It's generally a little bit more men than in 50-50 men and women, but more severe disease in men. Two basic peaks of onset, some around about age 20, another peak somewhere around age 60. Affecting 2 to 4% of the population. You go to places like Newfoundland, it's even much higher than the 4%, but overall it's somewhere globally about 2 to 3%. 70-80% of them have mild to moderate disease. And we know that moderate and severe cases need much more the biological treatments or subsequent advanced therapies to help them. And we recognize that it has a significant negative impact, particularly body image, self-esteem, stigma, shame, embarrassment, and this perception of being evaluated by others, feeling it may even be contagious. And again, psoriasis really has a profound effect on their quality of life. Again, median disease duration for many people is about 50 years. Particularly when its onset is at a young age, have fewer employment opportunities. And again, having effective both short and long-term treatment for psoriasis is crucial to produce this quality of life for our patients. So as I mentioned, the group of key opinion leaders got together, looked at this, did a literature review, and then looked at those guidelines, and then did search terms for further information. And included in the publication, we found 41 clinically relevant papers. There were 12 guidelines, algorithms, consensus papers, some reviews, and some randomized controlled trials that came up with this. And this is kind of the short list. And, you know, if you look at it, literally every year over the last 10 years, there's probably been about 12,000 publications surrounding psoriasis. However, very few of them address anything in terms of adjunctive skincare. And these ones were the ones that we kind of found in the literature that even mentioned skincare. So again, Mentor in 2008 said non-medicated moisturizers are applied. Salicylic acid maybe is something that can be considered. And you see all of these when, yeah, they mention adjunctive skincare, but that's kind of one line in each of these manuscripts. And again, in Emmett's, skincare as an adjunct should be considered in conjunction with prescriptions. Again, adjunctive skincare with gentle cleansers and moisturizers. But it's kind of one-liners in each one of these, and talking particularly about moisturizing the skin. And some of them talk about just using plain Vaseline to descale some of the lesions. Then we came up with 5 different statements, and this is one of the ones. Inflammatory skin diseases are often associated with barrier defects. The cause and effect relationship is complex for psoriasis, and it needs further studies. That was one of the statements that we came up with. And again, this is the cartoon surrounding this. I think because we do understand over the last 10 or 15 years, the pathways that are operative in psoriasis, we're able to treat patients much better. But we really recognize this as a skin disease. It's a systemic skin disease, if you would. And we understand a lot of the role of the IL-17s, IL-23s, etc. But very little has been done around the barrier function and helping some of the people. In fact, some of the people that have just mild psoriasis over their elbows or knees may do well with just a cleanser and a moisturizer rather than having to be put on topical steroids, vitamin D derivatives, vitamin A derivatives, etc. Oops, so too many, sorry. And again, we recognize that the dry skin and cutaneous inflammation associated with this impaired epidermal function has been mentioned. And this skin barrier dysfunction caused the release of further pro-inflammatory mediators that further exacerbate in the feedback loop in terms of inflammation. And again, complex, these are different statements in some of these ones that we found. The cause and effect relationship is complex. And we felt that, again, the epidermal barrier is dysfunctioned and has hyperproliferation of the epidermis in an attempt to repair the barrier. But there's certainly cytokines going on in the background that come to it. So we've gone a little bit full circle. In the up until about 1980, we felt all the action regarding psoriasis was the epidermis, was proliferating too quickly. And since about 1980, we recognized that there are cytokines systemically that are driving the epidermis and the barrier dysfunction. And each of these were different ones. This is Wolf basically saying that psoriasis and its gene mutations are associated with abnormalities. Cutaneous inflammation has an impaired epidermal barrier. And again, the breakdown of the skin barrier caused further release of these cytokines. And I think each of these mention it. They mention it slowly and a very small amount in each of the ones. We do also know there have been some studies that ceramides are depleted in psoriasis. So again, ceramides very important in holding the barrier function of the skin together. And this has been reported in several papers. Again, sparse literature when you go to actually look at the literature and you do a proper review. And again, stabilization of the skin barrier depends on these intact keratinocytes and the lipid synthesis. And again, animal studies, skin biopsies have suggested ceramides play a very relevant role in the pathophysiology of psoriasis. The old story of the chicken and egg, however. And then data on the use of emollients containing ceramides for psoriasis, either alone or combination, is extremely limited. So again, something that needs to be looked at further. The second statement that we came up was that guidelines and algorithms rarely even mention skin care for psoriasis patients, demonstrating a very important need gap. So again, this is a new concept, and a concept I think that's going to be looked at even more over the next years. And it'll kind of be like rosacea, acne, and atopic dermatitis that I spoke of before, that this is going to be part of our education for our patients. Topical treatments, we all know these. Again, if the disease is limited, we're using some of these topical measures. If the disease is more extensive, then we're using a systemic therapy, whether it's a small molecule or we're using a biologic to get the disease under control. And again, these are some of the things that can be added. Salicylic acid to remove the scale, a little bit of tar to add to help. Again, you can't use salicylic acid with a vitamin D3 analog because it inactivates it for the most part. And again, anthralin is rarely used by me anyway, and not very much around the world anymore. And again, this is some of the things moving to the next line in terms of first line therapies for more severe. And I think we use all of these different mediums, and it's been great over the last 10 years, 15 years to be able to have a great number of things. It wasn't that long ago that basically we had tar, topical steroids, ultraviolet light, and methotrexate. Now look at all the things we can use. And again, this is a pathway of that was recently done in 2021, and they just say topical treatment. They talk about use a little bit of emollients. That's it. They don't even talk about that this is an important part, educating about the emollients to go on the algorithm. And certainly a great guidelines by the JAD, the American Academy, basically doesn't even really mention that adjunctive therapy with emollients and cleansers is a necessary or integral part of this. And I think you're going to see that changing over the next years. So I'm going to pass it over to Dr. Kursick, good friend of mine. He's going to take it further, tell you further about why we should be using these and how we might use them to get a better effect. I'm going to reuse some of the literature surrounding this. Leon or Dr. Kursick, take it away.
Thank you, Chuck. So I'm going to take it over from here, but we will also start with a polling question number 2. So, do we need adjunctive skincare for psoriasis? And this is really almost a follow-up question from Dr. Lind, that do we see a place for the epidermal barrier function with psoriasis? So if we do, then do we need an adjunctive skincare for psoriasis? Yes, no, and always there is maybe. Wow. So 97% said yes. So I think we can finish the webinar here and we can all go home. But that is true. And I'm going to try to show that there is room for skincare. And this is our statement number 3 from that consensus statement, that skincare may play a role in the management of psoriasis, regardless of disease severity or therapy, both as adjuvant treatment of acute psoriasis and for follow-up treatment of healing skin and during asymptomatic periods. So just like the atopic dermatitis, number 1, when the patients have active disease, we certainly want to take care of them with medication, and regardless what that medication can be. You know, we are so lucky now, we have almost 12, 13 biologics in the United States, and then we have new non-steroidal topical treatments, and we have the topical steroids that we always go back to. And so regardless what we are using, I think the adjuvant treatment with gentle cleanser and moisturizer is a must. But then, just like atopic derm again, we need to use that regimen to keep and maintain the success of the treatment. So let's take a look at those options, right? And I think the most important thing here is that skincare should be used in psoriasis treatment. And sometimes, as Dr. Lind said, atopic dermatitis takes the thunder away from psoriasis, but still with psoriasis, as we can see, we do have linoleic acid deficiency. We do have ceramide deficiency, actually. And I'm going to try to show those to you with different references. And then, of course, when you start itching, and you know, in the old days, ironically, when I was a resident back in 1990s, my professor taught me that the first day in the clinic, well, if you cannot differentiate psoriasis from atopic derm or vice versa, you can cheat. And I go, how? And he said, you can ask the patient if he itches, then it's atopic derm. If it's psoriasis, psoriasis doesn't itch. Well, now we know that that is so wrong, right? That is very, very wrong. We know that actually psoriasis itches a lot, and those patients are miserable with the itch. So that itch scratch cycle also impairs the epidermal barrier in a vicious cycle. So therefore, we do need adjuvant treatment with acute psoriatic skin lesions. We do need, during the follow-up treatment of the healing skin, as well as the asymptomatic periods, to maintain the clearance of the skin and not to prevent relapse. And I'm going to discuss a study that actually shows that very nicely. Now, I think there is no question about the moisturizers and the gentle cleanser, how they help the skin barrier. We do need the moisture retention, but again, unfortunately, it is quite underused, under-discussed topic when it comes to psoriasis. And there are not much anything about the guidelines. We do know that the natural skin pH is acidic. It's the old timers called it acid mantle, and the acid mantle is somewhere around 5 to 5.5, where we want to keep that. And we can actually do that with certain moisturizers and cleansers where they have that acidic pH. Now, the other thing is we already heard about the keratolytic agents that we can use, such as salicylic acid and urea. Salicylic acid will serve the purpose with the acidic pH, but also it is actually a discriminative agent. It's a keratolytic agent. It is quite useful. And in the old days, those doctors that we used to do these concoctions, we always included salicylic acid with the topical steroids in order to remove the scale. And if you remove that thick scale, your medication is going to penetrate much better through the stratum corneum, right? So not only it's going to help as a moisturizing agent, but also as a keratolytic agent is going to help. And this can be other acids too, like such as lactic acid, glycolic acid, even TCA. But I don't see much role of the TCA, but mostly I'm thinking about salicylic acid and urea and sometimes lactic acid. Now, unfortunately, the other side of the coin is that they are irritating agents, right? So even though psoriasis skin, unlike atopic dermatitis, is not as sensitive, it still inflamed skin, it's still sensitive skin. So I think we have to be careful. So the marriage of a nice lipid-rich moisturizer and a keratolytic agent together in combination would be perfect and ideal solution what we're looking for, right? So you have your keratolytic agent, either salicylic acid and urea, with a lipid-rich, ceramide-rich moisturizer base. So now you have this combination as adjunctive treatment for your psoriasis patients. It would be the wonderful marriage in heaven with those two agents. So when we look at the what we have as keratolytic agents, I think we did mention the urea, and urea, by the way, as uric acid, it is also it's part of the natural moisturizing factor in the skin, and it does have that keratolytic effect. It does have that discriminative effect. It does have some antimicrobial effect, which will help. And it does reduce epidermal proliferation in addition to that moisturizing factor, right? Now, salicylic acid, not as much as the urea, but it is also keratolytic. It does soften the plaques, and it does actually help the penetration of the other topicals that we are using. Now, we have to be aware, though, sometimes it can destabilize other agents such as vitamin D and turns them into inactive. So we have to be aware of that, how we use it. But again, those two products, urea and salicylic acid, together with ceramides, will be the perfect combination for psoriatic skin. And then other things such as niacinamide, thermal water, of course, they have some anti-inflammatory effect, will also help. So our fourth statement was studies of patients with psoriasis applying topical moisturizers showed softened plaques, enhancing the absorption of topical treatment such as corticosteroids. The other thing that we forget always about the topical corticosteroids is that they also inhibit lipid synthesis. So if you already even if you have a normal epidermal barrier, it is gonna make that epidermal barrier function worse because it does prevent the lipid synthesis. It inhibits the lipid synthesis. All the corticosteroids, look, we use them all the time in atopic dermatitis, in psoriasis. However, we don't sort of think about their adverse event on the epidermal barrier. How can we overcome that adverse event? And very simply by replenishing the ceramides, by replenishing the lipids that corticosteroids are inhibiting, are taking away from the epidermal barrier. So we just have to make it up. So again, the treatment, combination treatment with topical corticosteroids and ceramide-based moisturizer will be very, very helpful. Our fifth statement was, studies applying ceramides containing skincare showed an overall improvement in the appearance of the skin and provided relief of psoriasis. These results suggest that improvements in epidermal function with topical emollients can prevent or attenuate the development of psoriasis. That's quite a bit of a heavy statement, the last statement there, and we're gonna go over it with a couple of studies. And you know, we probably need more evidence that topical emollients can attenuate the development of psoriasis, but certainly may help reduce the relapse, and we will see that. So the first study we're going to look at has published at JCAT, and it was a study done by Dr. Del Rosso, and they looked at CeraVe, which it is a ceramide containing moisturizer, as well as a cleanser as a regimen. And they actually there were the ceramide containing CeraVe here also contains salicylic acid and urea. And I think, as I mentioned, this would have been the perfect marriage in a combination world, that you do have ceramide containing moisturizer in addition to salicylic acid urea, which is going to act as a keratolytic agent for the psoriatic lesions, but also prevent that irritation that may come with the salicylic acid or the urea because of its lipid-based, ceramide-based moisturizer there. And this was basically, there were 33 male and female patients, 18 years of age older. Most of them had a history of mild or to moderate psoriasis. And then this was applied twice a day, 2 weeks with the cream, the moisturizer group. And then there was another group with the moisturizer and the gentle cleanser, and gentle cleanser was used twice a week. So what was in this ceramide containing skincare product composition? We had 2% salicylic acid, we had urea, and then the rest of the stuff you see as a glycerin, which is a humectant. I think that's also important. I'm going to discuss that a little bit. Niacinamide, there is some cholesterol, as well as the different ceramides, NP, AP, and EOP. So we always talked about, when we think about the moisturizers, right, we think about mostly occlusive, such as Vaseline, but you need also glycerin. And let me explain why. When you just have an occlusive moisturizer and you have a dry skin, basically you're occluding the dry skin, and there is no any moisture there, right? There is no humidity, so you're basically occluding the dry skin. If you have a only humectant-based moisturizer, then that humectants will attract the humidity from outside, from the atmosphere, but also from the bottom layer of the skin. Well, that humidity, moisture, the water, the hydration is going to come to the stratum corneum. However, because you don't have an occlusive, then that whatever you have, that moisture, that hydration is going to evaporate faster than it came, because your epidermal barrier is disrupted. So now you have a problem. You actually gonna get drier even faster. That's why in the old days, most old timers said, don't take a shower if you have atopic derm. Maybe you should take a shower once a week. Well, we know that that's not true now, because you can actually keep that hydration by using a nice moisturizer with a humectant and occlusive. So the bottom line is, in order to have a good moisturizer, you need to have the glycerin or a humectant. You need to have the ceramide and the cholesterol, as you need that occlusion as well. So the combination of those two, again, makes the ideal moisturizer. Now, this is unique, as we discussed. This includes also urea and 2% salicylic acid, and hence the use for psoriasis. So let's take a look at the results here. So what happened was 72, almost 73% of the patients who used the moisturizer alone had improvement in the appearance of their skin, overall improvement, and almost 76% of the patients who used the combination regimen, both the moisturizer and the cleanser, had improvement. Now, for the combined regimen, almost 85% reported it provided relief of psoriasis, and 91% reported that their skin felt soft and smooth. So here, again, it's the CeraVe body cleanser and the CeraVe body cream that is created for psoriasis patients with those two keratolytic agents, urea and the salicylic acid, but the base is the good old CeraVe ceramide base. Now, the next study, it's very interesting. It was done in China, and they used a homemade, I should say. This has nothing to do with a branded product, home-based product, linoleic acid and ceramide containing moisturizer. Now, linoleic acid, as you know, it's important part of the lipids in the barrier. As you know, the stratum corneum is composed of that lipid lamella, the bilayer. And actually, we know that linoleic acid is deficient in most of the inflammatory skin conditions such as acne and psoriasis. So what they tried to do here, they tried to basically replenish the linoleic acid and ceramide in this case, in the psoriasis patients. And they wanted to look at the acute phase of psoriasis, but then as preventive, as I mentioned, that we're gonna look at this as prevention and relapse, preventing the relapse of the psoriasis. So, and the basis about this, or the theory behind it, again, there are several in vitro studies that, for example, the levels of serine palmitoyltransferase, a key enzyme in the ceramide synthesis, were found to be significantly low in psoriatic lesions. So that brings us as a proof of the first point that I made in the beginning, that certain that ceramides are deficient in psoriatic skin because of the deficiency of the serine palmitoyltransferase, which plays a role in ceramide synthesis. The other thing is, we know the content of the ultra long chain ceramide is decreased in psoriatic lesions, which might be due to excess interferon. As we know, we have interferon and low expression levels of peroxisome proliferator activated receptor gamma, because excess interferon decreases elongation of very long chain fatty acids and ceramide synthase 3, and activation of the peroxisome proliferator activated receptor increases, and it also increases the long chain fatty acid expression. So the bottom line is here, to summarize this mumbo jumbo, because of the increased inflammatory cytokine and decreased receptors and decreased long chain fatty acids. Remember, long chain fatty acids play an important role in that lipid lamella, right? The short chain fatty acids are irritating and we don't want. We want the long chain fatty acids that play a role as emollient and play an important role in the epidermal barrier, and the decrease or the deficiency of those due to certain enzyme deficiencies that causes the epidermal barrier dysfunction in psoriasis patients. There is a bunch of references at the bottom of this slide. I thought those statements are very interesting, and if anybody wants those references, Roxanne can send them to you later, because I think it does make a good reading material for further discovery of this issue that we are sort of, at least I wasn't familiar with. Now, then let's take a look at the study. And basically, they had 110 patients. They randomized them into two groups. And one group got mometasone alone, and the other group got mometasone plus the linoleic acid ceramide containing what I call the homemade moisturizer. And then those groups, they get re-randomized again. Once they cleared, they received nothing or they received, I'm sorry, I shouldn't say they received nothing. They received the mometasone on PRN basis, or they got the moisturizer on PRN basis. So let's take a look what happened. So this is the primary outcomes. And remember, we are just dealing a moisturizer or mometasone, so they look at PASI 50. We're not, this is not a biologic, this is not a systemic medication. So when we look at the PASI 50 at week 8, this is during the first week 8, the patients who got the combination with the moisturizer, that number was 58%. The people who got just the mometasone was 16%. Quite a bit of difference. Then those people who got re-randomized, right, as maintenance treatment, look what happened. The PASI 50 was about 92% with the moisturizer group, and the mometasone alone was 50%. Almost twice these people accomplished with just the moisturizer to maintain their clearance. And the rates of the rebound was 45% and 10% respectively, depending on the moisturizer and without the moisturizer group. So the bottom line is, as we can see, a use of ceramide containing moisturizer is very, very helpful in addition to the traditional treatment, whatever that treatment may be. But I think in case of topical corticosteroid, the ceramide base containing moisturizer, it's much more vital because of the steroids, remember, inhibit lipid synthesis on their own. So in conclusion, we can say that in this case, linoleic acid and ceramide containing moisturizer is effective for both prevention and treatment of psoriasis. And then peroxisome activator, an ingredient in linoleic acid ceramide moisturizer, can override, here's the key word, can override glucocorticoid steroid induced epidermal functional abnormalities, as well as they can effectively inhibit inflammation and proliferation. Combination of linoleic acid ceramide moisturizer and GC could be a valuable regimen for treating and preventing psoriasis, just as we do in atopic dermatitis. The same idea, nothing more, nothing less. So the bottom line is here, remember what was the question, and almost all of you guys, 99% said that adjunctive skincare for psoriasis is necessary. Here we go. I circled it in red. I sort of knew you guys gonna go for it. And here we made the case that skincare plays an important role in management of psoriasis, regardless of disease severity and regardless of the treatment that we're using, topical, systemic, biologic, doesn't matter. Both as adjuvant treatment of acute psoriasis and for follow-up treatment of healing skin and during asymptomatic periods. However, we have to be fair and we need future studies on moisturizer containing ceramides for psoriasis, either alone or in combination with topical or systemic treatments, in order to see full benefits, because we always need randomized double-blinded studies, not just open label. So I'm gonna stop here. I think Dr. Lin is gonna join me and we'll take some questions. We have a polling question number 3. Now, do you feel that psoriasis, skin barrier defect disease in any way? Wow, 98%. I believe, Chuck, that number was 69% when you asked that, right?
Yep, that's right. So we've been very coincident.
Yes, exactly.
You know, Leon, just to make a point, I must admit, as I started the first part of the lecture tonight and everything else, and we started to do the little exercise. We were looking at this with the literature review and everything else. In my education with my patients, I rarely ever said, oh, by the way, use a nice moisturizer, use a nice cleanser. And since that, I have been putting that as part of my consultation. And you know what? Almost to 100%, the patients go, "Hey, Dr. Lynn, nobody ever talked to me about this before. I've seen, 5 dermatologists before you over my lifetime. Nobody ever talked. Is this a new concept?" And I go, "Well, not really a new concept, but it's kind of a concept that is an evolution. And I think it will be beneficial for your overall quality of life and your improvement with your psoriasis." Have you seen that too, Leon?
Yes, and you know what? I am actually guilty as charged too. I didn't do it either because I think we were so innately convinced about atopic dermatitis, and we always did when it came to atopic derm. I always did it with acne and rosacea because we knew that they had epidermal barrier dysfunction and they get irritated with the medications that we give. But honestly, I haven't done for psoriasis for a long time either. I just recently started within the last year or two, maybe. So I think we are learning, and the whole derm community are evolving that epidermal barrier function is a big thing in almost in every inflammatory skin condition.
So we
Yes,
do
sir.
have some questions from the audience. The first question is, skincare more important for mild psoriasis, only topical prescriptions, than severe psoriasis with the biologics?
I didn't catch the question, the beginning of it, Roxanne. I'm sorry.
So sorry about that. Is skincare more important for mild psoriasis, like only the topical prescriptions, than severe psoriasis with the biologics?
Well, I'll start that one. I think it's for all psoriasis, mild, moderate, severe. And again, as we've just discussed, we really weren't thinking about it. We were kind of going there, let's get that biologic, let's get them clear. But you still have patients with kind of dry, irritated skin, what I call the ashes after the fire, even when the biologic works and takes it all away. And I think it's important to recognize this and give them some proper skincare. And remember, when I was the CDA president, I coined the thing, dermatologists, you're skin experts, and we should be experts in all areas. And I think providing the best consultation for our patients is important. Leon?
I totally agree. I think regardless what the treatment is, what the severity of the disease is, but I have to add the fact that topical steroids, they actually make the epidermal barrier worse. They inhibit the lipid synthesis. It's almost a must that we have to replenish that lipids and the ceramides that actually steroids are taking it away or inhibiting the synthesis of it. So it is so important to replenish that with a moisturizer.
Yeah, Leon, you do a lot of clinical studies, and so do I. And normally in those clinical studies, they tell you you have to use a bland emollient. You must not use something that is active, that actually has ceramides. So certainly the pharmaceutical companies are twigging onto this, that these things by themselves can be of some benefit to making the disease better.
Absolutely. Even sometimes we have a washout period. You cannot start the patient on the study drug until they wash out a week or two, sometimes with ceramide containing moisturizer. So that means that the potency or the power of those moisturizers are very well known and understood.
So talking about that, what about Vaseline? Isn't this just as effective in terms of a petroleum jelly?
So let me start. Or you want to go, Chuck?
Leon answered. You go ahead, Leon. You answered it, I think, very well in your talk.
Yes. So it is not. And there are several reasons why not. Number one, Vaseline is just an occlusive moisturizer. And if you occlude dry skin, it's just going to remain dry and it's not going to do any good. And Vaseline does not really repair the epidermal barrier because it does not help to make the lipids, right? You're just occluding it. Now, ceramide containing moisturizer, especially CeraVe, is unique that number one, you're replenishing the ceramides that the skin barrier needs it and doesn't make it for one reason or another. Number two, the CeraVe, what I call, is not your grandfather's ceramide containing moisturizer because it comes in a very unique vehicle called MVE, or multivesicular emulsion, that basically it's a slow release or delayed release. Most of the moisturizers that you apply, their ceramide is going to be there for the next hour or 2 or 3. But in this case with the CeraVe, you actually, because it's delayed release, it's because of this unique technology, actually you have 24 hours of that ceramide being released into the epidermal barrier. So the short answer is no, it's not the same.
Yeah, I totally agree with you, Leon. And I think, in the old days, again, Vaseline was used as they were just basically taking the scales off, right? They were trying to get some relief, maybe a little bit of decreased itching. But you now have products that are targeted and are very beneficial, and they're not expensive. These are products that aren't very much more expensive than Vaseline. So why not use something that is beneficial and is relatively inexpensive to a person?
And also, I think, we have a lot of studies with those moisturizers versus Vaseline. I don't know how many studies is there with Vaseline. And those, as you put it, those sophisticated moisturizers are also very, very accessible, easy to get, inexpensive. They are on the shelf of, I don't know, CVS, Walgreens, or Jankatu, or wherever, right?
The Shoppers Drug Mart in Canada, I think, and
That's
Rexall.
right.
So another question, is there a difference in using these products in skin of color, since ceramides are felt to be important in those who have a filaggrin deficiency?
Yeah, I think we recognize and understand that the filaggrin deficiency is primarily in Caucasian and Europeans. However, I think there basically is a skin barrier defect in skin of color, and I think they should be beneficial in skin of color also. Leon?
Absolutely. Absolutely. I totally agree. Absolutely.
And Leon, you and I can do a lot of clinical studies. Skin of color has been definitely underrepresented in all clinical studies. And I think it's beneficial to actually, for companies to begin to do more studies around skin of color and to answer these things even more definitively by looking at skin types 4, 5, and 6, Fitzpatrick.
Yeah, I totally agree with you. Now, definitely psoriasis is more of a, what I call a middle-aged white man disease, but we still have quite a bit of skin of color patients. But atopic dermatitis certainly it's more of a skin of color patient. I think probably 30 to 40% of my patient population, skin of color patient, atopic derm population is skin of color. It's quite a high number. Psoriasis is not that high, but still we see quite a bit.
So this is the $100,000 question. Do you put the topical prescription first or the moisturizer first?
Can I get the 100,000 first, Roxanne? So this is really a very interesting question. Now, if you think about it, traditionally, what we were taught, and Chuck, please chime in here. If you apply the medication first, and then you apply the moisturizer, you occlude it so that you get the full benefit of the medicine rather than vice versa. So that was the teaching in the old days, right?
Yep, I agree.
So now, and this goes back to the acne studies, because we had some products that were quite irritating for acne, such as tazarotene in the old days, right? And we were trying to find a way to decrease the irritation of tazarotene. And going back quite a few years ago, Emil Tangeri from the West Coast, he suggested, what if we apply the moisturizer first and then the medication? Do we lose from efficacy or we don't? or also can the patient tolerate better. So I was part of that study that basically we applied CeraVe first and then the tazarotene, and then we did the opposite on the other side. And believe it or not, there was absolutely no difference in the efficacy. However, patients tolerated much better the medication. So at least we have a couple of studies now that was done that way that shows that it doesn't matter which one you apply first, your efficacy is not going to change, it's equal, but your tolerability is going to get much better if you apply the moisturizer first and then the active medication. But I think we certainly need many more studies in order to come to a solid conclusion. Chuck?
I think it's, I agree with you, Leon. The big thing is get the patient to use the product, right? If they find it too irritating, they're not going to use the product. So even if you're diluting it, and I get a lot of my patients with another drug, crisborol, they find that fairly irritating, much like tazarinic acid. And I usually put the moisturizer on first and then put the crisborol afterwards, recognizing that I'm probably diluting the full effect of the crisborol. On the other hand, patients tolerate it and they use it. So you end up at the end of the whole thing, getting them to comply better, and they're probably working better from that point of view.
Yeah.
Roxanne, I'll split the 50,000 with Leon. Okay.
Is it Canadian dollars or US dollars, Roxanne?
Leon, it's all Canadian, man. Unless you play for the NBA or the NHL, they get paid in the US dollars.
US dollars.
So if you were to design a good moisturizer, which ingredient would be the most important for psoriasis? Ceramides, urea, salicylic acid, or all of them?
All of the above.
Yeah, all of the above in a proper concentration. Remembering, Roxanne, that salicylic acid in a too high a concentration kind of denatures all the other products and it falls apart. So you have to have a good chemist. You know, that's one of the things I think, you know, I can remember the old days, Glaxo base was the kind of one of the best bases, if you would. But in fact, it's a lousy base. And we compounded and everything into it. We've got good chemists now. I mean, we've got products coming onto the market soon, topical, pharmaceutical base products that are just going to blow it away. They've got great chemists that sat down and figured this all out and are bringing us great products that aren't irritating and can be used all over the body.
Yeah.
Well, that's all the time that we have together. We'd like to thank CeraVe for sponsoring this educational event. And please join us for our next Skin Chat, which is going to be March 27th. And this one is going to be on xerosis in mature patients, skin barrier changes and consideration for skin care. So we'd like to thank Dr. Kursic and also Dr. Lin for a very enlightening presentation and really to a novel concept or therapeutic concept on skin barrier deficiency, skin care, and psoriasis. And we'd like to thank you all for joining us this evening. Good night, everybody.
Good night, everybody. Bye-bye. Take care.
Bye.
Bye.